Good afternoon, everyone, or good morning, depends on what time you will be streaming this lecture. Today, I'll be discussing patient-centered approach to TB care. Before I begin with my lecture, I would like to share you a story that will be most likely related to this module. We have one patient. This is based on a true story. Her name is Manang Rosita. Uh, as a patient, she is obedient and gets her medicine every day religiously. But upon observation on the continuation phase of her treatment, she seldom or does not go to treatment anymore. It was found out that Manang Rosita is a mother of three infants, and one of the baby is still nursing from her. So it all sums up to this lecture. As I was saying, Manang Rosita is an embodiment of what patient-centered to TB care should be. Our first slide discuss what is the meaning of patient-centered approach. According to Institute of Medicine, it's providing care that is respectful of and responsive to individual patient preferences, needs, values, and ensuring the patient's values guide all clinical decisions. In this day and age, we must be culture-centric and we should abide the culture of our certain patients. According to WHO, a patient-centered approach should enable patients to exercise their rights and fulfill their responsibility with transparency, respect, and dignity by giving due consideration to their values and needs. Our next slide, why is patient-centered approach important? As a background, the burden of TB in the Philippines remains high, especially in this time of pandemic. And it is also estimated that 581,700 TB cases emerging every year. Only 55% of estimated cases are diagnosed in 2017. And estimated 20,000 MDR-TB cases are emerging every year. And only 30% of estimated MDR-TB cases are diagnosed in 2017. MDR-TB treatment cases success rate is only by 50%, 54%, and high number, which is approximately 30% of MDR-TB patients are not complying with treatment. And every day, 60 Filipino people are dying due to TB. On our fourth slide, providing patient-centered care is crucial to achieving universal access to quality TB services for all people. High-quality TB care is essential to prevent suffering and death from TB and to cut transmission. High coverage of quality treatment is a fundamental requirement for achieving the milestone and targets of the NTB strategy and the SDG. The NTB strategy pillar 1 is the integrated patient-centered TB care and prevention. And according also to tuberculosis care, standard 9 is a patient-centered approach to treatment should be developed for all patients in order to promote adherence, improve quality of life, and relieve suffering. This approach should be based on the patient's need and mutual respect between the patient and the provider. Additional evidence-based policy recommendation on patient care and support, individual or package of interventions, support care, and the use of digital technology. Once again, the use of digital technology and implement effective approaches to treatment administration such as community or home-based treatment and decentralized care for drug-resistant TB patients. These are the following policies aligned to patient-centered care. First, throughout the continuum of TB care, healthcare workers shall respect patient autonomy and support self-efficacy. Second, the patient's physical comfort, safety, and wellness shall be maximized by providing evidence-based integrated care for TB and other comorbidities. Psycho-emotional support and protection from social isolation or discrimination shall be provided to all TB patients. And fourth, the impact of poverty and food security insecurity on TB diagnosis and treatment shall be recognized and addressed by linkages TB patient to social protection measures. Our following slide describes how respecting patients' autonomy and self-efficacy, supporting self-efficacy. As you can see in the picture on your screen, the patient is drinking in an open area, well-ventilated area. Perhaps this is a park, which is agreed upon by the patient and the health provider. We must develop a comprehensive patient assessment and individual treatment and care plan. Use a standardized patient assessment and care plan. Review and update plan monthly based on both clinical and non-medical needs of patients, including social, psychological, and economic. Prioritize patients with high risk of loss to follow up for supportive care and ensure confidentiality of patient information. Provide patient and family education on DSTB and DRTB disease and latent tuberculosis infection, including pertinent information on early diagnosis, disease transmissibility, and infectiousness, highlighting its impact on public safety and stigma associated with the disease. Provision to assist patients to comply with diagnostic testing such as specimens, transport. Provision of treatment on appropriate location and timing of their choice. One, for example, is the location of treatment can be at home, community-based facility, workplace, or health facility. Treatment partner can be an oriented family member, lay volunteer, community health worker, or health care worker. The use of technology, once again, by using video, DOT, missed call, text messages, to assist self-administered treatment may be considered. So in this day and age, we could use perhaps a messenger or a Zoom so that we could record patients habitually or religiously drinking the medicine every day. We must maximize physical comfort and safety and wellness. And regular monitoring and promptly treat side effects and adverse drug reaction. We must address comorbidities of the patient before the treatment of TB. Nutritional support as needed to speed healing and reduce the side effects of medication. Conduct baseline and periodic nutritional assessment. Provide general nutrition advice and among patients with comorbidities or requiring nutritional build-up. Refer to nutritionists for appropriate nutritional rehabilitation. Monitor, treat, and refer for comorbid physical conditions that affect the patient's ability to reach cure. For example, HIV and diabetes screening, counseling on pregnancy during DRTB treatment for women of reproductive age, and testing as needed. Assess for excess alcohol use, illicit drug use, mental deficits, or physical disabilities and refer as necessary. People with TB to smoking cessation programs like counseling and pharmacotherapy. Organize physical rehabilitation after cure. Patients who develop permanent physical disabilities such as hearing loss, which is rampant, and vision impairments as a result of the DRTB treatment will require physical rehabilitation after the cure. Offer palliative care for patients who cannot be cured. When all treatment alternatives fail and there is no possible cure, as confirmed by the TB Medical Advisory Committee or TB-MAC, a treating physician should consider palliative care or end of care as an option to DRTB case management. And provide psycho-emotional support and protection from isolation or discrimination. Maintain respectful communication and counseling between providers and patients throughout care, from initial consult to diagnosis, treatment initiation, and until completion of treatment. A. Provide interpersonal communication and counseling to empower patients to participate in decision-making in their own treatment And D, conduct periodic patient satisfaction survey. Regular monitoring and treatment of mental health condition that affects the patient's ability to reach cure. Conduct baseline and periodic assessment of the patient's mental health condition and as necessary. Make available ancillary medications to treat depression and other mental health conditions. And provide emotional support and encouragement to the patient and reduce social isolation and improve treatment adherence. We must assign a treatment supporter that is acceptable to the patient. Elicit support of peer and patient support groups, including patient support hotlines and mental support groups. Link patients and family with community-based organizations providing treatment adherence support services. And hold periodic celebrations of milestones accomplishment for the patients toward cure. Protection of the patient and family from stigma and discrimination in access to healthcare services, employment and community life, and facilitation of social rehabilitation. According to DOLE Order 50573, we must educate patients who experience workplace discrimination and in workplace policy. We must also introduce community outreach education strategy and aim at reducing stigma against people with TB in the community. Financial assistance to DSTB and DRTB patients to support diagnosis and treatment adherence. At PTSB, we give treatment allowance to patients who adhere to patients as per drinking of their medicine, taking their medicine. For DSTB, we could go to DSWD and other government service that could be provided to our DS patients. Provide financial assistance as needed directly, indirectly, or both as appropriate, including patients belonging to the indigent population and not simply from 4-piece households. Options include support for transport of specimen during diagnostic testing, as what we are doing with our Strider strategy, wherein we hire sputum transport riders to transport specimen from health centers going to RTB. Conditional cash grants provide to patients contingent upon treatment adherence. Unconditional cash transfers not linked to treatment adherence. And microfinance schemes support transport costs, food packages, and support for income generating activities. These interventions require coordination with other government agencies as well as non-government partners. We must refer patients to the appropriate national or local agency or beneficiary whenever available. To end our slide, I would like to go back to the story of Manang Rosita. As you can see, if without further investigation by our DHWD, it was not found out that Manang Rosita is pending for her children, whom she cannot leave to her neighbors or she doesn't have any relatives to secure the care of her children. So we must go to her house and bring her the medicine for her to adhere to the medication. The story goes on and on. This could be senior citizens who are bedridden. This could be PDL patients who are or previously uh, went to prison. This could be students who need to go to school, or this could be differently able patient who needs special attention, or simply an employee who needs to go to work and has no time to pass by the health center. This could be also a private person with depression or with a very high stigma that needs support and needs to be secured over of his or her treatment. And as we all know, no, that we must have a shift in our mindset wherein our patients are our clients and we, the health personnel, will have no job if without our patients because they are our clients. Here in patient-centered approach, we teach our health personnel that we must be